Inside a coronary artery, blood flow is dictated by a fragile balance. When a cholesterol plaque ruptures, the body's repair mechanism triggers a massive clotting cascade. Within minutes, a biological clot expands, obstructing the vessel. Acute coronary syndrome is a continuous spectrum of myocardial oxygen supply-demand mismatch. It describes a range of conditions that begin when that balance is suddenly disrupted. This continuum is driven by the physical mechanics of the obstruction. The size, stability, and duration of the thrombus determine exactly how much cardiac tissue will die. Emergency providers must translate this microscopic rupture into an actionable triage decision within 10 minutes of patient contact. To solve this problem in the clinical environment, providers rely on two pillars: the 12-lead ECG to track the heart's electrical footprint, and high-sensitivity cardiac troponin assays to measure the chemical footprint in the blood. Mastering this two-pillar matrix is the only way to accurately categorize patients into STEMI, NSTEMI, or unstable angina before irreversible tissue death occurs. To categorize these conditions, we first establish the clinical baseline for cell death. The fourth universal definition of myocardial infarction defines the exact threshold for confirming an acute infarction. This chart tracks cardiac troponin. Diagnosis requires acute myocardial injury, demonstrated by a troponin shift crossing the 99th percentile upper reference limit. This chemical signal must be paired with acute ischemia, patient symptoms, new ischemic ECG changes, or imaging showing loss of viable myocardium. There is a distinction between these two markers. Troponin levels definitively signal cell death, while the ECG shows the geometry of the ischemia causing that death. While the biomarker confirms the infarction, the ECG remains the primary tool for determining the speed of clinical intervention. Because troponin takes time to elevate, waiting for chemical confirmation can result in the loss of viable heart muscle. The universal definition sets the threshold for tissue death, but the ECG dictates the first major fork in the triage pathway. That triage fork is determined by the anatomy of the blockage. When a thrombus completely seals an epicardial coronary artery, all blood flow downstream stops. This complete blockage leads to transmural ischemia. The oxygen deprivation extends through the full thickness of the ventricular muscle, from the inner endocardium to the outer epicardium. This full thickness injury alters the heart's electrical vector during repolarization. As the current travels through the damaged muscle wall, it shifts the ST segment of the ECG trace upward above the baseline. This is the defining marker for an ST segment elevation myocardial infarction, or STEMI. To diagnose a STEMI, guidelines require new ST segment elevation at the J point in at least 2 contiguous leads. Current protocols also recognize a new left bundle branch block as a STEMI equivalent, as it signifies a massive conduction failure, often caused by the same complete occlusion. Because the full thickness of the wall is dying, emergent reperfusion is indicated. Clinicians must mechanically open the vessel using a balloon and stent, or chemically dissolve the clot with fibrinolytics. The timeline for a STEMI is measured in minutes. Guidelines mandate that the culprit vessel be opened within 90 minutes of the patient's arrival at the hospital. A STEMI is a complete physical blockage, a fully occluded pipe that requires immediate mechanical or chemical opening to save the ventricular wall. The presentation changes when the thrombus is only partially occlusive, or when blood flow is intermittent. In this reduced flow state, the subendocardium, the innermost layer of the heart wall, is the most vulnerable.
It is the furthest from the epicardial arteries and faces the highest mechanical pressure during contraction. Isolated subendocardial ischemia creates a distinctly different electrical vector than transmural injury. Instead of elevating the ST segment, the current shift typically causes ST segment depression and T-wave inversion. Because the ischemia is not transmural, the persistent ST elevation of a STEMI is absent. This clinical presentation, which can sometimes result in a normal ECG, falls into the broad category of non-ST elevation acute coronary syndrome, or NSTEACS. Because the electrical footprint alone is insufficient for a final diagnosis, clinicians must rely on the chemical footprint of troponin to differentiate between the conditions in this category. High-sensitivity cardiac troponin is the tool used to split NSTEACS into 2 distinct conditions. A diagnosis of N-STEMI occurs when NSTE-ACS symptoms are paired with troponin levels that exceed the 99th percentile upper reference limit. This confirms that cellular necrosis has occurred. However, severe ischemia can cause rest pain or crescendo angina, even if blood flow is spontaneously restored before cells actually die. If the patient has the symptoms of ischemia but their troponin levels remain negative, the diagnosis is unstable angina. This is the Braunwald classification system. It categorizes unstable angina severity based on clinical presentation, from new-onset exertional pain to angina at rest. Clinicians also distinguish between primary unstable angina caused by a thrombus and secondary unstable angina caused by increased oxygen demand. Though unstable angina lacks the biomarker spike of an N-STEMI, both conditions are often caused by the same underlying threat, an unstable ruptured plaque. Unstable angina is a herald of infarction. It marks the point where a patient requires aggressive intervention to prevent a partial obstruction from progressing into a full-thickness STEMI. There is a significant exception to the rule of plaque rupture, MINOCA, or myocardial infarction with non-obstructive coronary arteries. MINOCA is a clinical paradox. The patient meets the universal definition of MI, but angiography shows less than 50% stenosis without a visible clot. In these cases, the supply-demand mismatch is driven by other mechanisms, such as severe coronary vasospasm or microvascular dysfunction in the smallest vessels of the heart. It can also be caused by spontaneous coronary artery dissection, where a tear in the vessel wall creates a false channel that pinches the artery shut. MINOCA proves that ACS is defined by the oxygen mismatch at the tissue level, regardless of whether a visible atherothrombotic clot is the primary culprit. In the high-speed environment of the emergency department, these pathophysiological concepts are unified into a single operational flowchart. Modern protocols use high-sensitivity troponin algorithms to triage NST-ACS. By measuring absolute changes in troponin concentration over 1 or 2 hours, clinicians can rapidly sort patients into rule out, observe, or rule in categories. Very low baseline levels, or rapid spikes, allow for quick decisions, moving the patient either toward discharge or toward the cardiac catheterization lab. Patients in the observe zone require prolonged monitoring and echocardiography to ensure an evolving infarction is not missed. This unified matrix maps ischemic symptoms to ECG findings, then branches by biomarkers to diagnose STEMI, NSTMI, or unstable angina. The rule is consistent. ECG provides immediate anatomical triage, while biomarkers provide definitive proof of necrosis.
Ultimately, the modern classification of ACS is a dynamic translation of microscopic pathology into macroscopic, life-saving clinical protocols.